Hello, everybody. My name is Tang Mo. I'm a physician here at Mayo Clinic. I'm the director of the Interstitial Lung Disease Clinic, as well as director of our Pulmonary Vasculitis and Interstitial Lung Disease Fellowship. Um, this is my colleague.
Hi, I'm Cassie Kennedy. I'm one of the lung transplant pulmonologists.
Thank you for being here today. The topic of our discussion will be interstitial lung disease and lung transplant, what patients need to know. We'll begin with talking about the topic in general, both of them actually, and then entertain questions later on. So I'll begin. Both myself and Dr. Kennedy report no disclosures related to this topic. So I begin by discussing what interstitial lung disease is. You can take a look at this picture here, and what I like to tell patients is to think about this anatomically. Most people are familiar with diseases of the airways, with such diagnoses as asthma and COPD. Oftentimes when interstitial lung disease is talked about, they're not quite sure what part of the lung that involves. This picture highlights, for example, here the air sacs, and way down at the more microscopic level you can see where the blood and the air sacs meet to exchange gas. The space, which is not illustrated here very well, highlights the interstitium, or the space between the airways and the blood. This is the process that's involved in disease that we call interstitial lung disease. What happens here is any scarring or inflammation often leads to lung stiffness, and with that, oftentimes an inefficiency with gas exchange. So what are some of the symptoms? I would highlight specifically that the symptoms often are not specific. Oftentimes we do have shortness of breath that may come on suddenly, but more than often it's progressive over time. People do have a cough. Oftentimes that's dry, not very productive of sputum. It is a hallmark of this disease, but not necessarily specific for it. And then when you look at signs are specifically what physicians or clinicians see. You can hear lung crackles. There are stories of patients who go to their physicians and their lungs are heard to have this bubbling or crackling at the bases without any other particular symptoms, and a physician may get a chest x-ray or CT that will then pick up the fibrosis. But you don't have to have crackles to have this interstitial process going on. Finger clubbing is oftentimes seen. This is a specific enlargement of the nail bed. It has a specific look to it, and often signifies a disease that probably is a little more progressed than early disease, but it's something that people often pay attention to. And then maybe non-specifically, people also have low oxygen that's picked up, whether they have symptoms or not. Oftentimes they will have symptoms by the time you see some low oxygen saturations. So cough, shortness of breath, which are very non-specific, more often than not progressive over time rather than acutely, though that can also be the way lung fibrosis or interstitial lung disease can present. So when I see this, or many of us see this, most clinicians take the time to figure out exactly what they think is going on. And this is often done by going through a very extensive history, by reviewing things in your medical history, medications, exposures, and so on, to delineate if we can find a cause. And I'll highlight later on as to why that's important. But there are four broad categories that I want to highlight. Number one are autoimmune diseases. I apologize for not having this written out, but the connective tissue diseases, that's what the CTD stands for. Connective tissue diseases are specific rheumatologic diseases that have an associated lung fibrosis with them. They may or may not be specifically characterized by CT or by the way they present, but oftentimes we try to find out if they have a specific related autoimmune disease. There's also known vasculitis, certain types of vasculitis, specifically those that are highlighted by this serology. The PANCA and NPO can have patients who present with lung scarring. So the first broad category is autoimmune. This is often diagnosed in conjunction with a rheumatologist. Next broad category we think about is exposures, both organic and inorganic. I like to break it down to organic, meaning live things or living things. The main diagnosis in this category is called hypersensitivity pneumonitis. It's similar to an autoimmune process, but it's a self-derived molecular or a lower level allergy to specific live antibody or live molecules in the environment that then cause inflammation in the lung and can cause scarring ultimately. The inorganic exposures are broken down here. There are certain types of lung scarring that are related to smoking. This is distinct from COPD particularly. There are job exposures and then just things in the environment as well. I won't spend much time highlighting this, but oftentimes physicians will ask a lot of these questions to see if there's anything that you may have been exposed to that would help them understand why you're having the lung scarring. The third broad category is called iatrogenic. Iatrogenic simply means that medicine or physicians or when you seek care and things are done to you that can result in lung scarring or in this interstitial process in the lung. Two broad categories highlighted are medications and radiation. There are specific medications that doctors often check to see if you've had or had an exposure to. Radiation is particularly relevant in those who have chest radiation from having prior breast cancer or lung cancer. Oftentimes, as a collateral injury from having the radiation, the lung can be scarred, and taking that history would be important. And the last broad category is called post-inflammatory, or kind of a black box category. I think this is harder to define, but oftentimes people associate this with processes such as recurrent aspiration, where there's injury to the lung from having things go down into the lungs that shouldn't be there, or sometimes people are very ill from bad pneumonias and may have inflammation or injury to their lungs, and we oftentimes see scarring afterwards in that regard. There probably isn't a specific pathologic assessment for this, but this is one broad category that often is more of a not so much a throwaway category, but more one that we kind of defer to when we look through all of these and don't seem to find a specific etiology, yet there's other things in their history that seem to make sense that could explain the scarring. Next, we talk about the unknown causes. When you spend time and energy trying to find a known cause, and this doesn't seem to be the case, then I like to think of the unknown causes in three main ways. Idiopathic pulmonary fibrosis is a unique and distinct form of lung scarring that doesn't have a specific etiology, which is why it's called idiopathic, but yet it's defined specifically. We'll talk a little bit more about this in the ensuing slides. It's important because this is the most common of the unknown causes. There are 7 other idiopathic interstitial pneumonias. This is just the wording, the pathologic wording to define what type of lung scarring there is based on pathology. So if you end up getting a biopsy, there are 7 distinct entities that are not related to IPF that oftentimes are described as not having a known cause or that can occur independently of a secondary etiology. And in that regard, they are less common than IPF, but often are diagnosed and still primarily based on pathology rather than CT or your history. This last category here is something I call lung fibrosis of unknown etiology. I state this specifically because a lot of people don't follow through with biopsy, so we don't know specifically what's going on in their lungs, at least at that level, yet they don't have a specific diagnosis of IPF either, because IPF is specifically defined by CT and certain demographic features. When you fall into this category here, oftentimes it's just a temporary category before perhaps autoimmune disease is diagnosed or it becomes more defined as IPF over time. But this broad category here is often what a lot of physicians face when they can't find a specific etiology, yet they don't fit the definition of IPF. So how do we exactly diagnose this? As mentioned earlier, most of the diagnoses can come from history and exam. Oftentimes, because of the broad categories we talked about, both the physician and the patient have a hard time finding out or recalling exactly which specific exposures, which specific medications may be involved. And as the list is long, that effort should be paid close attention to, but may not often yield what we would like to know about the disease. Pulmonary function testing helps us understand any of the specific limitations that may be affecting you. In particular, it helps us grade based on the findings here where you may fall in terms of your presentation, in terms of how long the disease may have progressed. Though I do highlight that specific staging of disease is not based on this as much as it is just for us to follow progression. Chest CT is key and important. Chest CT is quite helpful, particularly in IPF, where many of the diagnoses can be made based on this. There are other characteristic features on CT that help physicians define any of the causes of lung fibrosis. As an example, the disease hypersensitivity pneumonitis may have a specific distribution or a specific finding that is different from IPF. and can help us understand this, oftentimes bypassing a biopsy. Bronchoscopy is highlighted here, and although it's not often used for assessing interstitial lung disease and may not contribute much, we often do it as a means of finding out any inflammatory cells that are in the lung that may be helpful, particularly in sarcoidosis or hypertension pneumonitis, and oftentimes to rule out infection or other causes. But the most important, if you want to define the underlying lung tissue, is surgical lung biopsy. This is often done by a specific surgeon to take out a larger piece of the lung tissue to study. And there are reasons to do that, and there are oftentimes reasons not to do that, particularly if the disease can be defined already by your history or your exposure or by the CT itself. So I highlight specifically here the criteria for IPF, because IPF is one of the more common and specific scarring lung diseases that still contributes to a significant degree of morbidity for people. And this criteria comes from an international consensus of folks, of experts looking at the disease over many years. Number one, as I mentioned here, we spend a lot of time and energy trying to exclude a known cause. And when we're satisfied or happy that there isn't a known cause, we look at the CT. And as I mentioned to you, CT is key because there is a specific pattern that the CT has with IPF that can often help people avoid a surgical lung biopsy. You can also go through a surgical lung biopsy, particularly if the CT is not helpful or is nonspecific. And ultimately, it requires a multidisciplinary approach, meaning the pathologist with the pulmonologist and the radiologist often sitting down discussing whether there are components of all three caveats, the CT, the clinical findings, and the pathology that could help define IPF. One question I ask myself is how old is the patient and what your gender is. I think this is key because when you are older and male, the likelihood of you having IPF is often higher. It doesn't necessarily mean you have it right off the bat, but it does help us predict whether you will have IPF, particularly if you fall into that category of lung fibrosis of unknown etiology at that point where you don't know exactly where it's coming from, but it still doesn't fit the IPF definition. If you're younger and female, oftentimes we will find a secondary cause. And when I mention younger, I'm probably thinking more in the age 50, 55 or less, oftentimes less than 50 years old. And if you're young and female, IPF often by definition can be excluded as time goes by, even if it isn't known right away. For general age, particularly if you're older than 70, whether you're male or female, the chances of you having IPF are slightly higher, or definitely higher. And then if you're less than 45, as I mentioned, it's unlikely to be a typical form of IPF. And although we may not find it on initial evaluation, particularly if you're young and female, there's often a secondary etiology. The next question we often ask ourselves is, what does a CT look like? And I highlight this again because like age and gender, the CT can help you appreciate broadly any specific diagnostic categories among the known and unknown causes that we had talked about. We may often get a high-resolution study, and if we're worried about any involved airway process, we get expiratory and inspiratory views as well as prone, meaning having you lie on your stomach during the scan so that we can get better views of the backs of the lungs. Most importantly, we try to look for old ones for comparison because it can help us understand rate of progression in terms of at least radiologic disease. So I'll give you an example. This is what we call the usual interstitial pattern, or the pattern that's often associated with IPF. And these are cuts from the lungs. Someone is lying on their back, and this is their right side and left side, and these are cuts right through them like a loaf of bread. And the white areas are higher density, so you see lung is black because it has lesser density here, and here's the heart. So we're looking at views near the bottom of the lungs, and you can see these abnormal areas here as if someone took a pen and was scratching along the lung here, areas of scarring. And these are areas of scarring that are very linear, very distinct. They're not covered over by haziness or anything else, what we call ground glass. And there are patchy areas here as well. I don't have a good example here of what we call honeycombing. Honeycombing looks exactly how it sounds. There is specific holes in the lung that are stacked together, at least two or more in a row, that look like honeycomb. It defines for us specifically whether it's IPF or not. If you were actually to take tissue from that part of the lung, you'll read out this pattern here, this usual interstitial pneumonia, which is a pathologic diagnosis. And this is the definition, this is the diagnosis that is defined by IPF, though I want to highlight that this is also seen in other diseases. But particularly this type of CT pattern is helpful for us if we're thinking that this may be IPF. I think it's important that we talk about defining a secondary cause. This is a chart looking at survival in people with IIP, or the idiopathic interstitial pneumonias, those that don't have a known cause, who fall into this category. And if you have a Collinger vascular disease or a CTD or secondary cause, you do better overall in general. And I think this highlights the fact that when there's a known cause, and it's not an idiopathic form, people often do well by the natural course of things. So if you don't find a cause, oftentimes you may have to have a discussion about things being a little, the prognosis being a little less or a little poorer than compared to finding a secondary cause. Even so, when we're looking at the course of IPF, which is the most common of the unknown causes, it's quite variable. The time of diagnosis can happen anywhere along this line, and people may live for quite some time, 5 to 6 years, versus presenting very acutely ill. And there's a phenomenon where people often have a stuttered decline, where they may become acutely ill and have less function afterwards, and have a series of acute illnesses where the lungs lose function quite quickly, and they may end up using oxygen or being quite debilitated. But at this point, there is no predictive staging process that people commonly use when you see a clinician to guess that you have several years or number of years or so on. But true IPF usually is progressive, with an average timeline between 2.5 to 3 years is commonly quoted. But now I suspect we're diagnosing disease sooner or earlier, and this may be stretched or longer, but it's going to be variable from one patient to the next. I'll highlight specifically, if you do have a known cause of lung fibrosis, the main focus is to use anti-inflammatory agents. We do ask that you avoid exposures. If there's an exposure cause, whether it's environmental or medication, people often begin with prednisone and then use other steroid-sparing agents here. This is an individualized discussion that should be had with the physician who has experience with treating this, and the dosing and the timing of things is often based on how severe the patient presents, how long they've had this disease, and if they've had exposure to treatments before, and if they had a response or not. Specifically for IPF, attempts at studying the treatments have been done, and these are listed medications that were used in trials in the past, which unfortunately have not been successful. But recently, as many of you may know, there are agents called antifibrotic agents, nintedanib and pirfenidone, which have been approved for use here in the U.S. I want to highlight several points. First is for IPF only, and so a clinician should make a specific attempt to diagnose this rather than to broadly treat all forms of lung scarring, as this is what it's approved for and studied at the moment in this disease only. And I do want to highlight that it's meant to slow disease progression. It's not a cure or reversal of the scarring or fibrosis or any interstitial process that's present. And when I say slow disease progression, we follow this with our breathing test to see if the numbers stabilize or don't rapidly decline. The efficacy or the value of each drug is probably equal. There's probably not one that's superior over another. And a discussion should be had with the clinicians experienced with lung scarring and treating this about which specific drug to pick based on your side effect profile and how much the patient would tolerate or prefer in terms of dosing. Other options that I'll allude to and will be discussed further by my colleague Dr. Kennedy include lung transplantation. There are ongoing research studies for both IPF and the other fibrotic lung disease or interstitial lung diseases, which I encourage you to seek out. And then we also focus on care of the patient in general, where the patient's symptoms, such as shortness of breath, such as the oxygen needs or their quality of life or mobility, are reviewed rather than the actual treatment as well, particularly if disease is prolonged. So looking at other comorbidities such as tumor or heart disease, sleep apnea, and other things like that that have been reported as perhaps more prevalent or as involved in this process of lung scarring is important when you speak with your physicians about what else you can do for treatment. With that, I'll turn it over to my colleague, Dr. Cassie Kennedy, who will talk to you about lung transplantation.
So when I encounter patients in the clinic, I find that very few, if any, of them have actually met somebody who's undergone a lung transplant unless they have a family member with an inherited disease who has also gone through the process, or if they're integrally involved in a support group for a type of lung disease that typically leads to lung transplantation. But for the most part, I think that lung transplant is a new concept for most people who are coming to meet us in the lung transplant clinic for the first time. And I do hear some misconceptions. So I want to first say that lung transplant is a complex medical and surgical procedure whereby we remove the diseased lung of the patient with lung disease and we replace it with a donated lung from a deceased patient that would have a healthy lung at the time of death. So at this point, unfortunately, we're not able to grow a lung or use stem cells to generate a lung for patients. We also are not able to use any animal organs for lung transplantation, nor do we have a total artificial lung like they have a total artificial heart. So there's no computerized form of lung that we can utilize. So we rely on the kindness of strangers to donate their own organs at the time of their death, or of family members who will donate their loved ones' organs at the time of death. And the recipient will either receive one, two, or sometimes two lungs and a heart during the lung transplant donation. Here on this diagram, you can get a sense for what the surgeon is doing. So you see this donated lung here, and you see that the recipient's trachea and main airways are left in place, and there's going to be a small portion of the airway from the donor lung that will be sewn on to the recipient's airway. Likewise, the pulmonary arteries and other pieces are attached, sewn into place, and usually the surgeon will do an approach either through the sternum, called a sternotomy, which is down in between the rib cage, or will do what's called the clamshell procedure, which is underneath the ribs. If there's one lung donated, sometimes it'll go through the side. The next question people often ask is who can have a lung transplant? So there are some misconceptions. I think what we try to convey in the transplant clinic is that a lung transplantation is not a clean slate. So you're not starting over without any sort of medical problems once you have a lung transplant, because it is a complex surgical and medical procedure that comes with a lot of medical surveillance and medication administration. It's something that we reserve for patients who have no other options or have limited other options. So we typically see patients who have advanced lung disease that have undergone medical treatment and are progressing despite maximum medical treatment, or have progressed to the point where medical treatment leaves them with either a shortened lifespan or a poor quality of life, or both. The patient should be otherwise healthy, so we're typically looking for patients who have limited, if any, other medical problems. And as I say here, we would try to balance that the risk of death without transplant is much, much higher than the risk of death with transplant. And we're looking for those patients where the quality of life will be better with transplant compared to quality of life without transplant. So we do about 2,000 lung transplants in the United States annually, which I think explains why most people haven't met anyone who's had a lung transplant. We're still a relatively small organ transplant program nationwide compared to some of the other programs like kidney and liver. We also are limited as far as the organ donors, so that we have about 1,700 patients at any time on the waiting list in the United States. The number of organs that we need is typically much greater than the number of organs that we actually have. The reason for that is that, as I said, we need to have a deceased donor's healthy lung. And a lot of the times the mechanism of death for patients who become organ donors is such that the lungs are damaged in the process. So we typically only use about 15 to 40% of the lungs that could potentially be offered up for organ donation. The question at the forefront of most people's mind when they are told that they have a lung disease is, how do you decide when to be transplanted? And I think it's a bit of a three bears phenomenon, meaning that you're kind of stuck with 3 time points. Either you're too well for transplant, you're too sick for transplant, or just right for transplant. And some of that, deciding where you are on the continuum and how much time you have to spend there, is a bit of looking in a crystal ball for patients, especially with interstitial lung disease, where acute exacerbations can be somewhat unpredictable. So I say on this graph here that the ideal timing for a lung transplant evaluation is just at the cusp of when you're an appropriate candidate for transplant. However, it's very difficult for you or your physicians at times to discern that. And so with interstitial lung disease especially, because patients are at risk for these acute exacerbations that may lead to a big sudden decline in their health and their expected life expectancy, we would rather see patients with interstitial lung disease, in erring on the side of too well for transplant, where we see you, we evaluate you, you feel a little healthy, we think you're a little too healthy, but then we have a nice system in place in the transplant center where we can follow patients. We'll see you every 3 months, and we'll make sure that we can identify this time where you're hitting the continuum of appropriate candidate for transplant, and we can get you on the waiting list. Most patients wait for lung transplant for a period of months. The average waiting time is 4 months, and since we don't know how long you will wait, because some of it is the availability of organ donation, some of it is your blood type, your size, whether you have antibodies to other potential donors, etc. We don't know how long that waiting time is going to be for you, and ideally your time where your appropriate candidate is about the time that you need to wait for lung transplant. But since we don't know that, we don't want to risk having you end up too sick for transplant. And then likewise, I said that the ideal timing for transplant is just right about that time where you're going to get too sick for transplant, so that you maximize your time without transplant, so that you maximize your life expectancy in general. The benefits of lung transplant: the short-term survival is quite good. The expected national survival for lung transplant is about 87–88% at 1 year, and so the short-term survival is quite good. The overall improvement in quality of life is on average better with lung transplant compared to more advanced lung disease. However, the average survival, or how long half of the patients make it following lung transplant, is about 5.5 years. And so that's why we want to time it so that you're not too well for transplant, so that we're really giving you a maximum chance at a long life expectancy. Longer term survival is possible. We have patients at our program who have been here since our lung transplant program has been open, so over 20 years. But we can't predict to a degree of who those 20–25-year survivors are going to be versus who's just going to have the average survival of 5.5 years. And so that's why we're careful about the timing of transplant. Most transplant centers will be monitored by CMS or the Medicare program, and so they will be required to post their 1-year survival rates. And so this is an example of our posting for Mayo of our 1-year survival rates. Right now, our current survival, which covers a recent time span, is 100% at 1 year, and then they will post whether the actual survival is different than the expected survival, and that's all available on the web looking at individual programs. What are the harms of lung transplant? So the reason that we don't transplant anybody and we look for patients who are otherwise healthy is that it's a very complex medical treatment. It requires a lot of follow-up. So there's a number of medications that come with transplant. We typically put patients on 3 immunosuppressive medications, and those immunosuppressant medications put patients at risk for infection. So they're typically on 3 infection type medications, and then there will be side effects typically from those medications, which will require patients to take medications potentially for the possible side effects. In addition, patients are at risk for cancers or post-transplant lymphoproliferative disease, and so that's why we reserve transplant for patients who really have limited other options with regard to management of their lung disease. Alternatives to lung transplant. So as you've heard from Dr. Mua, patients can undergo medical management. They can be enrolled in research trials, and some people would rather choose a path where they treat the symptoms, which is called palliative care, versus something aggressive like lung transplant. So how would you know if you or your family member would be eligible for a transplant? Typically, you would ask your pulmonologist for a referral. Although we do get self-referrals, we will need a number of medical records and questions answered by your primary physician. So it's easiest if you involve your pulmonologist early in that process. So if you self-refer, make them aware that you're coming to see us and get the records headed our direction. We typically perform a one-day consultation, and at that time we're basically looking for absolute contraindications to transplant. So, for example, if you had an active systemic cancer, breast cancer, or kidney cancer, or something that you were receiving chemotherapy, radiation, etc., you would not be a candidate for transplant at that time, because we would be worried that the immunosuppressive medications that we were giving to you would overwhelm the system and shorten your lifespan. So that one-day consultation, that is what we're doing. Then if it appears that there are no contraindications to lung transplant, we do 4 to 5 days of testing where you undergo consultation with pulmonologists like me, a lung doctor, the transplant surgeons, and a number of our subspecialists that help with the transplant care, such as our infectious disease specialist, our endocrinologist who deals with hormones, and we look at your bone density. We have you meet with the social worker, psychiatrist, Transplant Financial to see how much of a financial burden this will be on you and your family. And then at the end of that, we will meet with you and we will give you the results of all of the testing and consultations and let you know about any medical problems that we might have uncovered that need further follow-up. At that time, then we have a weekly selection conference, which is attended by all of the physicians that you have seen during the week. And it'll be multidisciplinary, and we'll get together and decide whether transplant is in your best interest or not. And there's really 3 outcomes that can come from that selection conference. Either you are an appropriate candidate for transplant and we offer you transplant listing. You're not a candidate and we don't think that there's anything that we can do to optimize you to help you become a candidate. Or there may be some remaining issues that we either need further testing of or that you need to optimize before you can undergo transplant listing. Once you're listed for transplant, you can be called with an offer at any time. And so we typically want to be able to get a hold of you and your close family members so that we can alert you as soon as possible if there is an organ available. Organs are allocated based on how sick you are, and so you're on a list with others of your blood type, and the sickest person on the list who's an appropriate size, who doesn't have any antibodies to that donor, would be offered the organ first. And each region of the country has an organ procurement organization, and so there are potentially 1, 2, or more other transplant centers that also have lists that have a combined list. If there's nobody available in that region, then the organs are offered out to other regions based on level of sickness. And how they determine that is called a lung allocation score. The transplantation itself, we have you come here within 4 hours, so most people will fly. If you're local, you can drive, and then you're admitted to the hospital. We do a quick screening, and then you're prepared for the operating room and brought down to the operating room. You undergo the surgery, and then typically you're brought back into the intensive care unit, and you're there for 1 or 2 days, and then you're brought to the general floor, and eventually you're dismissed. One thing that people misunderstand about the lung transplant process is that this isn't a surgery that you undergo to get dismissed from the hospital and go home. We typically keep you in Rochester here for 90 days so that we can keep a close eye on you and make sure that you're comfortable managing your new organ and that all of the medical conditions are stabilized before you head home. And then we do see you back every month initially, and then every 3 months, and then every 6 months. And so there's a lifelong commitment to the program where you have this lifelong connection to the physicians who helped you go through the transplant. So how do you choose your lung transplant center? Because there's that lifelong commitment, you really should look at the rapport with the pulmonologists who will be taking care of you. I think you want to make sure that there's local expertise for all of the complications that could potentially befall a lung transplant patient. So do they have the appropriate infectious disease physicians, social workers, psychiatrists, transplant financial, etc., that can help you through the transplant process and any of the complications afterwards. Review your finances. Occasionally there's an insurance company preference for a transplant center or a few transplant centers that you'll have to pick from based on your current insurance. Geography plays into it a bit. Some areas of the country do not have a transplant center available, and so patients may come from many states away in order to find that transplant center. You can look at the outcomes, as I said. The short-term outcomes will all be posted on the web, and so you can compare those one-year outcomes. Most places in the country would be followed by CMS and approved by CMS, and so you definitely would want to look for a center that is CMS approved. If you go to a center that doesn't have CMS certification, there is some risk that if you were to go on Medicare at some point because of age or disability, that CMS would not help you pay for your medications. And then I would say take a look at some of the extras, the pulmonary rehabilitation program to make sure that you're getting the exercise and the expertise with exercise that you need following transplant to make sure that you're back up on your feet and as active as you can be as soon as possible. Things like, I have a picture here of our Gift of Life transplant house. So we have access to affordable housing following transplant that's much, much cheaper than a local hotel would be. So those kind of things should also weigh in. Support groups. We have a caregiver support group once a month for the patient's family members who are helping to take care of transplant patients. And then we have a weekly transplant support group for the patients who are either waiting for transplant or who have undergone transplantation. So I think that builds that camaraderie and support that you need for some of the questions that are not necessarily medical but important. So in summary, lung transplant is a last resort option that can improve the quality of life or survival for select patients. Average waiting time is 4 months, and candidates will have a lifelong relationship with their transplant center, and so should make a careful consumer choice for that. So now we're going to move into the question and discussion portion of this webinar, and so Dr. Moule will kind of navigate through the questions that have been sent in, and then we will do our best to answer those.
Thank you, Dr. Kennedy. We have a question that asks, this patient was particularly diagnosed with NSIP 3 years ago, and they are asking specifically what to look for as the disease progresses. To clarify, NSIP stands for nonspecific interstitial pneumonia. So it is both a disease entity, but it's also a term used to describe pathology. I'm suspecting that you were diagnosed with this specifically by pathology, because oftentimes it's difficult to diagnose by a CT alone. To answer your question, it's difficult to say from day to day how someone would progress, but I would look for the typical symptoms of shortness of breath, cough. Oftentimes, if you are with a physician who is familiar with this disease, they will check breathing tests. They may check a CT perhaps once a year or every 2 years, just to see if the scarring process or the fibrotic process or any of the process in the lung there is changing over time. And the one caveat I would add is that by comparison, oftentimes NSIP progresses much slower than the more common one that we talked about, which is IPF. And that's not a guarantee oftentimes, but overall it does do a bit better. And the last thing I would add also is that if you do have NSIP, there's some thought that perhaps there's a secondary cause. So certain things like autoimmune diseases and so on may start showing up depending on your age. And oftentimes, as I mentioned earlier, if you have a secondary cause, for a good majority of those people, they often do better than the one that we're worried about, which is IPF. Yeah, Dr. Kennedy, anything to add to that? Do you transplant a lot of NSIP patients?
You know, the NSIP patients that we see at the transplant center are usually what we kind of term fibrotic NSIP, meaning that NSIP in general is thought to be a little more treatable or related to a secondary cause. But at some point, there's enough damage done that is not reversible that the patients would benefit from lung transplant just because their quality of life is poor. They're on continuous oxygen supplementation. They have an exercise limitation. Maybe they're not able to work, and so then those are the patients that undergo transplantation for NSIP. Sometimes those patients worry about a recurrence because the cause of the NSIP has not been identified. And I would say that we don't typically see a lot of recurrence of underlying lung disease in lung transplantation. The main things that we worry about, as I said, were infection, rejection, or development of a cancer or a lymphoma rather than recurrence of underlying disease.
The second question that was brought up is which drugs could possibly lead to interstitial lung disease, and that's a great question. When I highlighted in my talk that under the iatrogenic topic, or the topic where physicians or the medical care causes injury to the lungs, there's a whole host of drugs, and sometimes what this blends into is kind of a post-inflammatory response. There may be an acute reaction with the medication that causes inflammation or injury to the lungs. If that happens enough, maybe that may lead to scarring. Specifically, one participant asked whether interferon or ribavirin taken for Hep C could be responsible for NSIP. I'm not quite sure that I could answer that question directly in the form of finding off the top of my head any particular studies and so on. There is a website that's called Pneumotox, and we as physicians use it quite often. It lists medications and it lists the injuries that are associated with them that have been reported in the literature. And I would refer the writer to that, to type it in and see if that's the case. But to specifically say that has led to NSIP is often difficult to delineate. How we know a drug may cause lung injury is that we suspect it does so, and we stop the drug, and oftentimes that the patient will get better, the symptoms improve, and the radiologic features get better. We may often use an anti-inflammatory like prednisone to help that process. One writer asks about macrobid or nitrofurantoin. Macrobid is a common drug that is listed as something that can cause lung injury. I'm not quite sure that I can quote to you how many times you have to take it before you have lung scarring specifically, but it is one that is known to do that. It's hard to disprove that that's not the case, and so if you have been on the drug, oftentimes we may bring that up in our discussions and have people avoid that. Nowadays, I don't think we would try to biopsy the lung because there's nothing specific that would delineate the drug-related toxicity on pathology. So we make that clinical assumption and we stop the medication. Here's a question from a patient. If a patient gets a single lung from one of the writers, if a patient gets a single lung transplant, does the doc also remove the bad lung?
That's a very good question. So as I said, sometimes patients get a single lung transplant, sometimes they get a bilateral or a 2-lung transplant, and sometimes they get a heart lung transplant. And basically when you're going through that 4 to 5 days of testing in order to basically we're coming to a conclusion of your candidacy, but we're also coming to a conclusion of if you were to undergo lung transplant, what type of lung transplant do you need? And the things that we look at is if you have bad organisms, aspergillus or atypical mycobacterium, etc., in the lungs, or you have areas that look like bronchiectasis or fluid-filled areas that we worry that they might be harboring untoward organisms, then when we do transplant, we do insist upon a bilateral lung transplant because we're basically trying to remove any potential of infection coming from a native lung that would put your health at risk following transplantation. The other thing we look at, which is pertinent to interstitial lung disease, is whether you have high blood pressure in your lungs. And so most people know blood pressure, which is usually taken on your arm. That's kind of the blood pressure of your whole body, coming from the left side of your heart. And the blood pressure in the lung is actually something that only can be estimated by echocardiogram or measured directly by a catheter that we do during the lung transplant evaluation. And so if there's high blood pressure in the lung, then we will also insist upon doing a bilateral lung transplant. If you just have a diseased lung, IPF, for example, but there's no infectious organisms there, and your lungs are doing about equal work, there's no high blood pressure in the lung that would preclude you from getting a single lung transplant, then oftentimes it's to your advantage to be listed for a single lung or bilateral lung transplant in case the donor offer were to come through from somebody who had damaged one lung through trauma, but was donating the other lung. And so we make that decision pretty carefully. But just having IPF in a native lung or having COPD in a native lung doesn't necessarily mean that the lung has to be removed at the time of transplant. We can do a single lung transplant as long as there's no high blood pressure in the lung or bad organisms in the lung.
Great. One of our writers also asks if someone or their loved one gets a transplant, are the anti-rejection medications there for the rest of their life?
Yeah, so that is a good question. That's some of the consideration that goes into whether or not you want a lung transplant, is that there is quite a bit of what we would call treatment burden or medical burden that goes along with a lung transplant. So typically patients are on 3 immunosuppressant medications following transplant. There may be medication side effects or biopsies without rejection that will eventually lead to that being weaned down to 2 medications. But for the most part, patients can plan to be on immunosuppressive medications for the rest of their life, with the amount of medications higher at the time of transplant. And then as we see transplant organ stability, we do wean those down. But you would be on some degree of immunosuppressive medications for the rest of your life.
And Dr. Kennedy, some of our writers are interested in the age limit for lung transplantation. Have you heard of anyone who was transplanted beyond the age of 75 or at 75?
Yeah, so we don't typically preclude patients based on age for lung transplant, but the problem is that as people age, the more their body ages. And as the body ages, they're going to develop more medical problems that go along with that age. So I think the oldest patient that we have transplanted here is 72. I have not heard of somebody getting transplanted nationwide older than 75. And it's not an age discrimination per se. It's just whether the person has the vigor and the health to undergo such a complicated medical procedure at that age.
Okay. One writer is wondering whether GERD or reflux disease is a diagnostic cause of lung scarring, and that's a great question. I think there may be some comments from the transplant side of things as well too. I would answer that by saying that in the universe of possible diseases, GERD or reflux disease is very common in the population, but lung scarring, for example, is not. And so whether GERD directly is a cause of lung scarring, I don't think that that has been definitively proven in any form of pathologic pattern, just because of the fact that there's so much GERD out there, but there's not as much lung scarring or lung fibrosis. Now, whether people have aspiration into the lungs leading to further injury of the lungs, that's probably a believable process. Some observational studies suggest that people with lung scarring who don't have GERD treated or aren't on medications such as Prilosec or omeprazole don't do as well over time, and that's usually inferential data. And then there's some concern right now, and some people are studying the relationship between profound reflux and those who already have lung scarring. And there's actually one study that's actively going on where people are doing surgeries to treat the reflux disease, and then watching survival in lung scarring over time to see if that is a process. I don't know how to explain it so well, but I guess my understanding would be that if you have a proclivity or a likelihood of scarring, any other injury to the lung may lead to more scarring, and so if you have reflux, that may contribute towards it. But I can't say that the lung scarring originally began with reflux or poor reflux. That may not be the same in pediatric patients. I suppose that there are some patients that are described in the pediatric literature who have a lot of aspiration and they end up with scarring, but I don't know if that's definitive for the typical diseases that we call IPF or the other fibrotic diseases. I wonder what you think about that in terms of risk for transplant and so on.
Yeah, so we typically ask about reflux disease at the time of evaluating patients with interstitial lung disease because of the paper that you quoted that shows that patients tend to live longer if they are on anti-reflux therapy or if they've had an anti-reflux surgery. Now, just because we found that association doesn't mean that the reflux surgery or the reflux medication causes the prolonged life, but in the absence of a lot of other great options and little harm associated with some of the anti-reflux therapies, we do encourage patients to go on anti-reflux therapy if they can tolerate it. We do, after transplant, worry about reflux as well because it seems to have some association with the rejection of the graft or the dysfunction of the graft long term.
Great. I have one question here from a writer who asks specifically about CT findings that initially looked like sarcoidosis. They underwent a biopsy, perhaps of some kind, that suggested a disease called hypersensitivity pneumonitis, and the audience may remember that's one of the exposure diseases to something organic. I describe that as either mold in the environment or bird protein as the most common ones here. This patient, or this person, didn't have any exposures, but his disease progressed anyways after he left that particular environment, and he had to be started on prednisone. The question is, can hypersensitivity pneumonitis worsen even if you don't know what caused it and you went out of that environment? Can things get worse? I'd have to say that the diagnosis of hypersensitivity pneumonitis is very difficult to make, oftentimes more than IPF, and the reason being is because of that very fact that we don't know specifically what in the environment causes it. If you look in the literature or talk to physicians who are used to this, they can name 100 different things, 100 different kind of etiologies that could do this. We often base this on that exposure history, our diagnosis on that, and then blood work. We obtain serology. Sometimes antibodies are formed to this that we try to detect. And then they may or may not have a typical CT pattern that fits with this. Pathology often is very helpful, but there could be some nuance as to whether this looks more like sarcoid or looks more like hypersensitive pneumonitis. And so with that in mind, to answer your question, I think that there are cases of patients who have what we call chronic hypersensitive pneumonitis who continue to decline. I have patients myself who have sold their home, who've left the city or left a certain environment, left the country where they thought they were exposed to certain things, and many months later still have decline in their function status and still have a decline in terms of worsening CT findings. That may not be unheard of. How do you treat that would be one question that is difficult to answer, and oftentimes we may have to leave someone on an immunosuppressant for a longer amount of time, such as prednisone or one of the steroid-sparing agents. Do you transplant a lot of chronic hypersensitive pneumonitis?
We do. I think it's a very frustrating disease for patients to have because they're basically getting the news from the physician that something is causing this, and yet out of the 300 potential causes, we can test for a handful of them, and so it's very frustrating to know that something is causing a problem, but not being able to narrow down what exactly is causing that problem. And so patients will be, if they continue to progress, will be on a large amount of immunosuppressant medications, and they may still continue to progress. And eventually they get to kind of a fibrotic hypersensitivity pneumonitis or a chronic hypersensitivity pneumonitis phase, where really their best option at that point is transplant. And we do see those patients. And again, for whatever reason, we don't see a lot of recurrence of the hypersensitivity pneumonitis following transplant. But every year we're evaluating a number of patients with kind of unresponsive hypersensitivity pneumonitis.
Great. We have time for one to two more questions, and I think this is a good one leading to what you just talked about. For example, the chronic hypersensitivity pneumonitis. And someone who is transplanted and they've reached the 5 or 6 year mark, what's the chances that they may get another transplant just because of whatever reason?
Yeah, that's a really good question. So transplants after transplant can occur because of recurrence of underlying disease, which is pretty rare, or more likely because of a chronic rejection or chronic, what we term now chronic lung allograft dysfunction, meaning that the lung that was transplanted in is no longer healthy enough to give a good quality of life or good function to the patient. And patients who are at that point would again have to go through a transplant evaluation with a number of subspecialty consultations and studies to see if they're fit to go through another transplant. I think that's the rate-limiting step for retransplantations, is that because of the immunosuppressant medications and having already gone through a complex surgical and medical procedure, some patients, and then patients are older, and so they may get more comorbidities with age. They may not be fit to undergo a retransplantation, but certainly that is a possibility if patients remain healthy. And if patients have had a single lung transplant, sometimes they would get a subsequent single on the other, or sometimes they would go ahead and get a retransplantation. The outcomes for retransplantation are not as good as for initial transplantation, so that has to be taken into consideration at the time of the evaluation. That it's going to be a harder or more difficult procedure for the patient to undergo, and so are they fit to undergo that procedure?
Well, we have time for one more question, and I think we could probably answer this in regards generally to how the known causes of lung fibrosis are treated. The question is, what is the success rate of CellCept or mycophenolate as a drug that would lessen progression? I'm assuming progression of ILD. And then someone asked, how can you get off prednisone? What's the best way to wean off prednisone? I'd begin by saying that definitively none of these drugs particularly are helpful for IPF. So these drugs should not be used for IPF as a standard way of treating anyone. So I would hearken that towards more of the secondary or known causes of lung scarring. Mycophenolate has been given some credence for treating in a relatively safe way the connective tissue disease or autoimmune lung fibrosis diseases, even in patients with chronic hypersensitivity pneumonitis that we've talked about, where they've been on prednisone for quite some time and now we want to take away those side effects. We may put them on mycophenolate as well, 6 months to a year or so. For weaning off prednisone, I don't think there is a specific pattern to this other than to probably go by the rule of thumb that if you're on it for probably 4 weeks or more, you should probably take that same amount of time going off of the drug and wean over it over some timeline, over several weeks instead of several days. And that is a judgment call that's often made between you and your physician rather than something that's a textbook approach. I want to thank everybody for joining us today and answering these very good questions here. If you are interested in learning more about this or in setting up an appointment, there is a link at the bottom of the screen or display that we could help with referrals or with discussing any future concerns. So I'm Tang Mo. Thank you so much.
Thank you very much for joining us today.